In 1990, neovascular age-related macular degeneration, NAMD, and diabetic retinopathy, DR, were the leading causes of vision loss and blindness in older and middle-aged Americans, respectively.
I finished training as a vitreoretinal fellow in 1991, and at that time, treatment for many retinal diseases was really limited or non-existent. Neovascular AMD caused 90% of AMD-related blindness. And to treat neovascular AMD, all we had was laser photocoagulation that cauterized the abnormal blood vessels, but damaged the neural retina and led to a scar formation and loss of vision. It was a treatment that was not something that doctors liked to do or that patients really appreciated.
In the 1950s, the development of proliferative diabetic retinopathy was actually a risk factor for mortality at that point in time. In the 1960s and 70s, about half our patients were going blind every year from the condition. Now, after the 1970s, the development of laser panretinal photocoagulation reduced the risk of blindness by about 50%, but still there was a great deal of visual loss, and the laser treatment itself had some side effects, mostly built into the fact that laser was destroying areas of retina. There were problems with peripheral vision and night vision. So the need was for both a more efficacious treatment that could save more sight for proliferative retinopathy, also particularly for diabetic macular edema, where the laser helped prevent getting worsening but didn't really improve it, and also for a therapy that wouldn't destroy the retina in order to have these benefits. So when anti-VEGF came along, not only were we no longer destroying areas of retina to have the benefit, but the beneficial aspects of it were about twice as much as the laser were, and the side effects and the risks were 3 times less. And so this brought about a very rapid change in our primary therapies for these conditions.
Beginning in 1991, the National Institutes of Health, NIH, funded physician scientists identified the principal cause of vision loss in these diseases, vascular endothelial growth factor, VEGF.
We all grew up in ophthalmology knowing that there was a mysterious factor X that drove abnormal blood vessels in eye diseases. And investigators had been searching for factor X for decades. With the discovery of VEGF in the 1980s, and the fact that it was both secreted and driven by hypoxia, we in our group were excited that this might actually be factor X. When we could then show that VEGF inhibition completely prevented neovascularization in animal models, we began to get even more excited. And with our small clinical study, and then the larger one by Lloyd Aiello and George King, showing an association between VEGF and abnormal blood vessels in the eye, including proliferative diabetic retinopathy, we knew we were really onto something.
The development of anti-VEGF for the eye is actually a fascinating story, and one of the aspects of it is that it was first identified as a factor in cancers. And by looking at some of the studies that come out for cancer, it became apparent that this molecule both caused endothelial cells and vessels to proliferate and also caused them to leak. And those were 2 fundamental characteristics of the complications in certain conditions, and particularly in diabetic retinopathy, the area that we worked in. And so the question became, could one factor be causing these 2 major problems that result in visual loss from diabetic retinopathy? And as we started to study this factor, we found very rapidly it had all the characteristics that had actually been proposed for such a factor nearly 50 years earlier. It caused vessels to grow, it caused them to leak, it was increased when there was not enough oxygen around, it was diffusible within the eye, and it was found in the eye, and particularly in these conditions. And it was in about 1994 or so when the first studies came out where we looked at VEGF inside the eye in relation to these different conditions, where we found that it was dramatically increased in things like diabetic retinopathy or central retinal vein occlusion or retinopathy of prematurity. And once we had that association, then it became very likely that if we could find a way to block this factor, we would have benefits. And although that took many years to show, down the road these therapies became remarkably effective, for the first time actually improving vision in some of these conditions where at best before you were trying to maintain vision, and then became really the first line standard of care around the globe for these eye diseases.
In 1998, NIH-funded scientists partnered with biotechnology companies to launch the first anti-VEGF trials in ophthalmology.
The initial results were incredibly dramatic. The treatment with the anti-VEGF inhibitors, once the studies were unmasked and one could see what the effect of the actual drug was compared to not using the drug, was dramatic improvement. Not only did it prevent the worsening, but there was dramatic benefit in terms of improvement of visual acuity in many of these conditions. And that had really not been seen before for the conditions that were being studied.
For a long time, I actually had studied a different growth factor. When I was a postdoc at Hopkins, there was a very well-known ophthalmologist there who studied eye diseases in babies called retinopathy of prematurity. And it turns out to be an application for which anti-VEGF is actually being used now. And while I was there, I tried to find an angiogenic factor from the eye, and I found FGF, not VEGF. So I worked on that for a while. And then I came back to Boston as a first instructor and then an assistant professor at Children's Hospital in the group of Judah Folkman. He had a big angiogenesis laboratory.
The clinical trials of the anti-VEGF drugs were supported by private industry, including iTech, Genentech, Roche, and Regeneron, to name a few. Post-approval, NIH funding was used for the comparative effectiveness trials of the various drugs, in particular for AMD, and that would be the CAT trial.
He also had Tony Adamus working there. Dave Scheimer was a graduate student with me, and Joan was a fellow at the time. And we were all sort of working together virtually across the river, because we were down the river, actually. We were at Children's. Joan was at Mass Eye and Ear, although Joan used to schlep from Mass Eye and Ear to come down to my lab meeting, our lab meetings where we discussed this. She was very dedicated. So it was sort of a totally, I wouldn't say spontaneous, but a meeting of the minds of people who were all asking the same question. And we were doing laboratory research on it. As I said, we were, Joan had the animal model. We would get tissue from that. Dave Scheimer would run a Northern. That's what we were doing at the time, show there was message. Then we would get the fluid out and be able to do an ELISA to show that the VEGF was there. And then Tony and Joan would be able to visualize it and see that the blood vessels were there. So it was really a collaboration. It was the classic, it takes a village. And then the actual demonstration of inhibition, Tony and Joan initiated a collaboration with Napoleon Ferrara at Genentech at the time, who had developed a neutralizing antibody, which was actually developed at that time for use for tumors. So the initial development of anti-VEGF was for tumors, the angiogenesis and the leakage. People were doing a lot of tumor work. In parallel, we were doing work in the eye, because actually the differences are not that big. I mean, tumors have excess blood vessel growth and are a problem because they grow uncontrollably and they're leaky. The eye has a problem because vessels are growing uncontrollably where they shouldn't be growing and they're leaky. And it turns out the mechanisms are quite similar. It's hypoxia, it's excess VEGF. So nature is very economical in her use of molecules. And so we learned from the tumor people, and then the tumor people learned from the research that we were doing in the eye. A lot of crossover.
Since the introduction of anti-vascular endothelial growth factor drugs, legal blindness from neovascular age-related macular degeneration and diabetic retinopathy around the world has been reduced by half.
It's had a huge impact on the treatment of patients, initially patients with wet AMD. It's been called a number of things, such as a miracle and paradigm shifting and revolutionary.
Anti-VEGF has been a game changer. Diseases with no treatment or with very limited treatment are now controlled and treated with anti-VEGF therapy. Millions of people are treated annually around the world with anti-VEGF drugs, and vision has been saved for countless people.
From the basic science viewpoint, it's also been paradigm shifting because it's wonderful and heartening and inspiring to be able to see research, basic research that's done that goes right from the bench to patients and then has such a dramatic impact.
The development of VEGF was really a successful partnership of federal funding, private enterprise, and philanthropy, and really all parts were essential. Federal funding really supported the basic science discovery of VEGF itself and some of the translational work that led to its development for treatment for patients.
NIH funding was crucial for the discovery and the early development of anti-VEGF therapies, particularly with regard to identifying VEGF as a key factor. It was NIH funding that helped discover VEGF as a key factor mediating cancers, and that was the insight that allowed many of us to think perhaps it would be worthwhile also in the eye. Once we had data that there was a likelihood that the VEGF in the eye could theoretically be mediating these conditions, it was NIH funding that allowed us to characterize that in detail, proving the fact that the VEGF existed in the eye, proving that it could have the effects of permeability and neovascularization, and starting to characterize how it worked, what its receptors were, what cells made it, and how that might be regulated.
For the kind of work that led to this, which is discovery work, which was, at one point me taking cow retinas and putting them in PBS to extract angiogenic factors, that was all funded by the NIH, as was the early work that we did in the laboratory. So that kind of discovery work requires federal funding because it's a leap. And companies will fund research, but they are more interested, biotech and pharma, they're much more interested in funding sort of the application of whatever discovery you've made. So when it comes to discovery, coming up with the hypotheses and doing the key experiments necessary to test the hypotheses, federal funding is essential because it doesn't come from really very few other sources will fund the kind of discovery work that's necessary to come up with these kind of observations that lead to this endpoint.
For 2 years, I did not need any of the intravitreal shots. After the 2 years, I started receiving the shots. There's a lot that goes through your mind at that point, just having somebody put a needle in your eye. At that time, there was also fluorescein angiography, and I had to go through that process. This was about 19 years ago. From that time on now, I have been receiving the shots for 17 years, every 4 to 6 weeks or 10 weeks. It seems to have progressed to a point where I've gone from myopic macular degeneration to dry and now to wet. But also things are changing along the way, and the extension of my leaky blood vessels needs a shot usually every 10 weeks instead of 4 to 6.
Patients with macular degeneration were like a bucket with a hole in it. They could only lose vision for a time, maybe preserve it with the available therapies, but not really have any hopes of getting more water or more vision in the bucket. Anti-VEGF therapy changed all of that, and now it's become, for many patients, a treatable disease. Anti-VEGF therapy is the use of drugs that block a molecule called vascular endothelial growth factor, or VEGF, and blocking its action on blood vessels in the body. VEGF, the naturally occurring substance in our body, has many actions, some beneficial and some detrimental. One of the actions VEGF has is making blood vessels leaky. So if you can think of pipes that are old that may be staining the ceiling as water is dripping, this is an action that is done by VEGF on certain blood vessels in the eye. The use of an anti-VEGF restores the integrity of those blood vessels and fights the leakage and therefore the resultant fluid that damages the retina, whether it's in wet age-related macular degeneration or diabetic retinopathy. Anti-VEGF therapy is one of the, if not the biggest revolution in retinal care in my career. The only other one that would come close would be the application and use of vitrectomy surgery for conditions within the eye. We had therapies that might be able to slow it a little, but we didn't have any really effective treatments to preserve or restore visual acuity.
My visual acuity is, the last time it was checked was 2040, which that has not been in a while, in my left eye. And my right eye fluctuates between 2050 and 2070. So reading, I can read with reading glasses. And I probably should mention that I had cataract surgery also. And that has helped a little bit. Although one of the doctors did say it's a treatment. It's not a cure, but it will help me to see better.
The impact of anti-VEGF medications on the quality of life of patients with age-related macular degeneration, diabetic macular edema, retinal vascular occlusions is enormous, absolutely enormous. And let's put it in practical terms. We all fear blindness greatly because it's a tremendous limitation to normal activities. For example, imagine trying to go to the grocery store. You're an older person living alone. You need to buy eggs and milk and other things in order to make your meals. Well, let's say you, number one, are having difficulty cooking, and number two, you can't even get to the grocery store walking those 2 blocks safely because your vision is impaired. You can't read the labels once you're there. You can't check the prices. Now you get an anti-VEGF medication and your vision is improved, and suddenly you can say to the butcher, no, I don't want that cut of meat. I'd like the other one on the right side of the case. And you're back in life. How wonderful to be able to participate in the day-to-day activities that make our lives so rich and so meaningful.
I do still drive, so that's a huge help as far as in the way of independence. I like to read, I like to hike. I feel very good about where I am in comparison to where I was. If I had not had the shots, some of my optometrists and other doctors have said I may have lost the sight.
Prior to anti-VEGF therapy, wet age-related macular degeneration had very poor treatments. I remember I was a fellow at Bascom Palmer Eye Institute in 1982 when the first macular photocoagulation trial results were released. In that treatment, we attempted to burn the new blood vessels to prevent them from reaching the center of vision, that is the fovea. We had literally nothing. Since that time, a number of treatments were introduced. There was photodynamic therapy, which had some benefit, introduced in around 2000, and then drugs that could slow the loss of visual acuity, but not really improve it, really until the introduction of anti-VEGF therapy. Similarly with diabetic retinopathy, we did have laser treatment, but no way really to address diabetic swelling in the macula or macular edema. But now with anti-VEGF therapy, we have a powerful tool and we can reverse the swelling and improve the acuity for many diabetic patients. For example, a patient with wet age-related macular degeneration, obviously typically an older patient, who's looking forward to many of the wonderful things that older age can bring, putting photos in albums, reading to grandchildren, taking trips with loved ones to see loved ones, etc. And they're quite concerned when their vision is threatened. So I say that we will begin a treatment. Yes, it requires an injection into the eye, which sounds really scary at first, but actually it's over in a couple of minutes and has become one of the most common procedures in all of medicine.
Yes, it's scary, but once you've gone through it, you realize that you don't feel it. People often say, oh, an injection in the eyes. Well, I do know about the numbing process and all of that. So you don't feel it. And I often say to people, if I pinch them, that would hurt more than when you get the injection.
And that this treatment has the strong prospect of stabilizing or even improving their visual acuity. After that, I don't find a lot of patients anymore who resist the idea of the shot. They're actually quite eager to get their vision back. And so some patients will require shots every month. Some patients will require shots at lesser intervals. But I would say that people are generally quite enthusiastic about the fact that there is a treatment.
Anti-VEGF has saved countless patients from going blind and has helped them live fuller lives. All of this would not have been possible without scientists, clinicians, the collaboration between industry, the National Eye Institute, and federal research funding.
The role of federal funding in the development of anti-VEGF therapy has been absolutely critical. It begins with the basic science that demonstrated the role of VEGF, or vascular endothelial growth factor, in ophthalmic disease. Federal funding then subsequently supported the critical clinical trials that allowed us to demonstrate the benefits of anti-VEGF therapy in diseases such as age-related macular degeneration, diabetic retinopathy, and retinal vascular occlusions. Those clinical trials now serve as the benchmark by which ophthalmologists in the United States and throughout the world manage their patients. The impact of these treatments is truly without measure. The return on investment for the dollars provided by the federal government to stimulate research in the anti-VEGF area, in my opinion, those dollars have resulted in treatments that now have a major impact on patients and in particularly Medicare beneficiaries' quality of life. These treatments prevent blindness. Prior to the advent of anti-VEGF therapy, more than 90% of patients who developed wet or neovascular age-related macular degeneration were blind within 1 year. Anti-VEGF therapy has reversed that loss such that less than 10% of patients who are on active anti-VEGF therapy become blind at 1 year. And remarkably, more than 50% of patients on anti-VEGF therapy maintain visual acuity of 20/40 or better. That level of acuity allows patients to drive, to read, to see their grandchildren. The financial return to the federal government also includes the decreased morbidity from injuries such as falls, diseases such as depression that are clearly associated with legal blindness. The impact of anti-VEGF therapy on our current healthcare system is considerable and has been revolutionary. The cost per injection varies significantly between the drugs that the physician and patient choose.
Since the advent of anti-VEGF therapy, the treatment of blinding diseases and Medicare has become the #1 expense for Part B drugs.
And in fact, the drug aflibercept, also known as Eylea, is now the most commonly prescribed and highest expense in the Part B drug space. When we combine aflibercept with another very effective branded anti-VEGF agent, ranibizumab or Lucentis, those two drugs constitute approximately 15% of the Part B drug expenditures. Now that sounds like a lot of money, but I would note that the price of those drugs has not been raised by either of the manufacturers since their onset into the market. And that dates back to 2006 for Lucentis and 2011 for Eylea. I would argue that when one considers the quality of life that all these treatments provide, that anti-VEGF therapy is among the most cost-effective treatments in all of medicine. Within the anti-VEGF space, we have 3 commonly used drugs. We have 2 drugs that are specifically approved by the FDA that were developed by industry. And we have another drug that was approved by the FDA for other diseases, but it was found through investigation funded by the National Eye Institute and others that this other drug is often equally effective to the branded drugs. This drug is known as bevacizumab or Avastin, and it is approved for the treatment of cancers. But it was discovered by ophthalmologists that Avastin can also be effective as an anti-VEGF agent in the eye for the treatment of diseases such as age-related macular degeneration, diabetes, and retinal vascular occlusions. Well, why would that be important? It's important because the cost of Avastin is much less than the cost of the branded drugs. Avastin costs vary between $50 and $100 a shot. This is of critical importance for our patients who can't afford the higher priced drugs that are approximately $1,800 to $1,900 a shot. Even with insurance, in the current era of high copays and deductibles, many of our patients struggle to be able to afford the branded drugs. The use of Avastin has allowed us to open this therapy to people who may not be able to otherwise afford it. There have been studies that have looked at the potential savings that could occur if everyone was treated on Avastin as an initial therapy. And these run into the tens of billions of dollars over a decade. We know from data in the IRIS registry that currently approximately 43% of intravitreal injections are done with Avastin. If those injections were done with the branded drugs, the cost to the healthcare system and to the federal government would be significantly higher. The reason we know that Avastin is often an appropriate and effective alternative is because of the support from the federal government that has allowed us to perform clinical trials. These clinical trials have demonstrated the efficacy of Avastin across multiple diseases. This is not to say that Avastin is the right drug for everyone, but it does allow physicians to choose the most effective drug for each patient within the context of costs and also within the context of treatment burdens.
The future of anti-VEGF therapy is very promising. We know that this therapy can stop these blinding diseases.
But anti-VEGF therapy comes at a cost, and that cost is the need for close clinical follow-up. Many of our patients need to be seen as frequently as every month or two. This obviously results in significant logistical and transportation issues for our elderly patients. These issues have been aggravated by the pandemic. Ideally, what we would like to develop are therapies that are even better than what we have with anti-VEGF therapy and diminish the treatment burden. And there are some very promising technologies that are trying to do exactly that. The first involves drug delivery devices that could be implanted into the eye to allow for a slow, sustained release of anti-VEGF therapy, such that patients would only require treatment once every 6 to 12 months. A second therapy might involve gene therapy. This would allow us to turn a patient's eye into a mini factory that could actually manufacture anti-VEGF drugs within the eye and thereby eliminate the need for continuing injections. The third possibility is to identify drugs that will last longer, such that we may only need to do the injections once every 3, 6, or perhaps once every 12 months. Already, all of these technologies are in clinical trials, and we are very optimistic that these technologies will diminish the significant treatment burden associated with anti-VEGFs.